Hello, this is Dr. Hassan Adeem. Today I'm going to show you how I got a complication and how I dealt with it without CTR or 3-piece IUL. So let's start. It was a pretty simple case, started regularly, routine VM blue was injected and I started the Rexis after putting the soft shell technique. So here was the first mistake. The patient was moving too much and the rhexis margin got a little larger than expected. So, but it was regular and it was not extended. So I decided to move for hydrodissection and next step. But the problem was the nucleus did not rotate easily and it was unable to rotate on 6 o'clock and I can see the whole bag moving. Still, I thought I can manage it, so I went for FICO. Then I started a horizontal chop, a short chop, but it was not complete. It was not full through, full thickness. So I tried to do it again. It was too much pushing and too much. And second mistake was pushing the nucleus too much. That was my second mistake. I should have gone for more energy and more deep dip inside the nucleus, so that less manipulation. Now I could see a dialysis of Sonews there and I could see the fold of the bag moving towards the 12 o'clock position. Now I realize my mistake. Now I immediately rotate the chopper to 12 o'clock to flip the nucleus and change the orientation so that that piece should come out instead of dipping to the posterior capsule, through the posterior capsule. I could see there was no wedges coming out and I could easily get the piece. So I tried to, now I am more cautious. Whole nucleus is shaky. There is a lot of the movement in the back. So I tried to I increase the energy and tried to take the piece and putting dispersive viscoelastic and pushing the back. Now I perhaps whole nucleus in AC and did complete the whole FICO with the remaining. So thankfully the nucleus was not so hard enough and power was, now parameters was low and I could see the back there, but thankfully there was no vitreous prolapse through the posterior chamber. So I tried to fill the bag and put the IUL in the anterior chamber with haptic outside. And now this is the tricky part, how to manage this kind of case. Let's see. I put on a lot of gel, then simply gently pushing the haptic inside the bag, keeping the optics over the pupil. So I put one haptic there, then put the gel again, and then tried to push the other haptic also in the bag. But the orientation of the haptics are different than the 6 o'clock zonular dehiscence. Never ever put the haptics inside the zonular dehiscence position, otherwise it will tilt or drop. Now I'm removing as much viscoelastic as possible safely with having a very low flow from cannula so that there is no prolapse. Now final step. Now I am gently pushing the optic inside the bag so that the pupil become regular, especially on the 6 o'clock zonular side. Now no more gel washout is needed. IUL is well centered. Hydrosealing of the wound and also putting on antibiotics and air bubble inside and moving the speculum. Thank you so much for watching.